I've had multiple patients who sit in front of me emotional because they were like, I wish that I knew this information sooner. Because sometimes they're, outside the window of opportunity to prescribe hormone therapy. And I'm like, is it too late for me? And I'm like, there's so many other ways that we can support you as well, not just through hormone therapy. But these women, wish that they had this information in perimenopause or even in their 30s to know what to expect from their bodies when they reach that age.
Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast. Hello, everyone, and welcome back to the Advanced Women's Health Podcast. I am so excited to be here today with Dr. Natalie. Before coming on, we were just chatting a little bit about how, honestly, so many conditions can look like something else. And we'll talk about that with Natalie's story today. But one of the things we're going to get into is how you can become so passionate about a condition as a practitioner because of how you identify with it, how it shows up in your body. And I think this is something that we often don't see, right? Like, I lost 100 pounds. I also had mono. I had all these things. People don't see that now when they see me, right? I slept 20 hours a day at one point in my life. I now have a decent amount of energy aside from today. No joking. But you look at these things, right? And people don't see that. And I think that it's so important to dive into that journey because within that, people can feel so supported and understand how you're going to approach care. So with that intro, let's dive in today to who is Natalie. I would love to hear you just walk us through like what got you into naturopathic medicine, who you are, what you're passionate about, and we'll go from there.
Perfect. Well, thank you for having me, Sarah. I'm so excited to be here. Pretty much just a quick overview of who I am is I grew up in Sudbury. I'm born and raised here. And so I practice out of the Advanced Women's Health Sudbury location. I did my undergrad in kinesiology in Ottawa. And then I took a couple of years off where I taught fitness classes, yoga, ran some triathlons. And then we went to CCNM, Canadian College of Naturopathic Medicine, to get my doctorate degree. And then from there, worked a little bit in the GTA and then came back to Sudbury just to be closer to friends and family and have a more of a community, and just have been working here since.
Yeah. So walk us through that, because we were just talking. You're like, I taught fitness classes and did triathlons, and like you look like that. The most love and respect in the world. You look like the person who would do that, but that's not always been your journey. So I would love for you to walk us through that experience of now being where you're at. Where did you come from? Like, how did you get into this world? How did you become so passionate?
So, like we were chatting a little bit before the podcast, I have always been interested in health and fitness. That's kind of why I went into kinesiology, wanted to explore yoga, fitness, all of those things. But then right in my fourth year, I started to really not feel well. And it kind of threw me for a loop because I've never felt the symptoms that I was experiencing before. I went to my medical doctor several times and just was kind of dismissed, unfortunately. And then I started to gain weight, be extremely fatigued, have panic attacks that I've never experienced before, start to not recognize myself when I looked in the mirror. I would have, as we now call it, classic moon face when we have a low thyroid Hashimoto's picture. And that's what I ended up being diagnosed with once I finally went to an endocrinologist. But when I stepped in that endocrinologist's office, they gave me a prescription of Synthroid, weighed me and told me I was overweight and just to take the medication. And that was it. And follow up, in a little bit of time. And I just left the office crying because I'm like, I've never experienced these symptoms before. I kind of want to know what's going on. At that time, I didn't really have an understanding of health. I didn't know, understand how to put anything into words. And so I sought out a naturopathic doctor here in Sudbury. And that was the first time that I really felt heard, validated in my feelings, respected. She really walked me through everything that was going on in my body. From there, I just had subsequent visits with her, use nutrition, supplementation, and help me get back on track. And I mean, I owe her so much, but that really made me want to become a naturopathic doctor myself, is to give patients the voice that I feel like I didn't have sitting, across from that doctor.
Yeah, absolutely. And one of the things you didn't mention that we were chatting about before is like you didn't gain 10 pounds, right?
Yeah.
I'm gonna call it out for you because I think it's important. Like you gained 65. So that
Yeah.
is an amount of weight that changes how you feel in your body, how your body moves, how your body functions. And I call it out not because I think numbers are important. And I want to be clear. And I think everyone listening to the podcast knows that, but because there are so many people sitting on the other side of this, listening to this right now, who have gained 40, 50, 60 pounds, 100 pounds, and they walk into a doctor's office and they're like, eat less, exercise more, essentially imply that you're lazy. And it's something I talk about a lot, and I think people really resonate with my story. Like, I honestly was probably more healthy when I was 100 pounds heavier than I am now. I, like, ate perfectly. I exercised every single day. I thought I was stressed. I definitely was not, right? But I slept, I did all of the things. But when hormones and inflammation are driving weight gain or driving dysfunction, there is no amount of restriction outside of true and utter starvation that is going to change your weight. You will lose lean mass, body mass, you will leave like so many things will be sacrificed. But it's really critical that people hear this because I think sometimes we still think of it as this like imaginary thing, right? There's still that underlying current in social media that it's like, girl ended up lifting 5 pounds more weight and did progressive muscle training, and all of a sudden her body transformed. You know what I mean? Someone gave up gluten and everything changed, gave up dairy and everything changed. And like, as much as I love those conversations to a certain degree, I think it's really critical that if you're feeling that, you're working with someone who understands, who can help support you, and who can do the right testing because it's just so overlooked.
It definitely is. And I mean, at this point, this was over 10 years ago. I was 20. I was so young. And coming out of that kinesiology, I looked into the mirror and I did not recognize myself, right? And then not only are you feeling tired and fatigued and don't understand why you're feeling this way, it also puts you into kind of a deeper depression, right? And that cascade effect is often what
Totally.
we see with our patients is you may not want to exercise because you don't have the motivation, right? You don't have the
Yeah.
motivation or the energy to prepare healthy meals. But then when you're not, socializing like you used to and don't maintain those interpersonal connections and relationships, it really sets you down a darker path. And I mean, I came out of that kinesiology background thinking that all I needed to do was exercise more and restrict my calories. And I mean, I see that all the time with patients, right? Is that's what they tell me is like they're weight loss resistant because they've been doing all of these things, but it's not working. And so that's where we
Mhm.
really are able to take a deeper look and, dive into blood work. What are hormones saying? And kind of fit an approach for that particular patient based on their needs.
Yeah, absolutely. And I think it's, again, I really like to highlight these stories because as we're going to talk here about perimenopause and is it perimenopause, this is an experience that's so consistent with women in that age category. Anywhere between kind of, I always say like 37 and 42 is when it starts to and then we see it again. But those symptoms of not feeling in control of your body, symptoms of hot flashes, night sweats, waking up in the night, headaches, mood changes, depression, body changes. I always say, because I've been actually gotten quite a bit of hate historically about like body positivity. And I'm like, I am not at all telling someone what their body should look like or what health looks like on someone's body. Those are not conversations I'm having. I'm having a conversation with a person who's doing all the right things. They have goals for their body to feel and potentially look different, and they want to achieve that. and that what they are doing is no longer working. Things have changed. And I always say, I could give a rat's ass what you look like. I want for you to feel in your body how you want to feel. And if that means that your body sits at a higher, what we call like BMI, I don't care. If you feel good and you are confident and you feel like the effort you put in, you get out. If you're in a situation where that is not true and you're feeling lost and out of control, that is where we come in and we step in and we can support someone, whether that is hormonal, meaning fluctuations in estradiol and progesterone, whether that is hormonal, meaning cortisol is driving that, or whether that's hormonal, meaning insulin is driving that. These are all chemical signals that are telling our body what to do to protect itself. And if you're protecting yourself against something that is optional and that we can eliminate, why wouldn't we do? Is my thought process.
Exactly. And I mean, that's the approach that I think patients really appreciate that we take. And then, I love bringing those like evidence informed options to life and seeing the reward from patients and feeling better in their bodies, losing weight finally and, feeling their optimal self.
Absolutely. So you love perimenopause. That's something that conversations we had early on is that's an area that you're really passionate about. So how did you navigate into that space? Like what was that journey to finding that population that you loved?
I mean, two reasons. One, I always wanted to come out of school and I knew I wanted to focus in an area. I just wanted to know that I wanted to dive deep into research in a particular area and become kind of an expert in that, just so I could provide a lot of clarity to patients. Secondly, even though it was 2021 when I experienced all of those, you know, health concerns, I really felt like I was in perimenopause or menopause, right? I was waking up drenched in sweat, gaining weight, not having the confidence, feeling out of control, not being able to sleep. And these are the exact symptoms that patients are telling me in the moment of how they're feeling. Unexplained anxiety, unexplained panic attacks that I had never had before. And this is exactly what kind of perimenopause, menopause women are explaining to me. And so, although I am not at that age to go through that, I do feel like I have some relatability and experience. And so I can have empathy to that, right? I know what that's like and I know to take those things seriously. And we need to create a plan of action to make sure that those patients are not feeling that.
Yeah, absolutely. And it's, again, just like in your situation, it's modifiable, it's figure outable. I think with the perimenopause conversation, honestly, with any health condition, it's so easy to be like, I was diagnosed with X and therefore this is my journey. It would be so easy for you to say, oh, well, my thyroid's not working. This is my reality. And this is going to be the rest of my life. It's so easy to say, you know what, my ovaries aren't working the way I want them to. This is just going to be the beginning of the end and accept those symptoms. But it's a whole nother thing to say, no, you know what? I deserve more. I can achieve more and really drive for that. And I think that's something that we both love in a patient population is people who are like, you know what? This is not going to be my reality. And you're right. It is something that oftentimes women in that mid 30s to mid 50s are coming back to themselves in a really beautiful way. And I think it's so powerful to get to support them.
And especially women at that age, there is a lot being asked of them, right? They are often taking care of their parents, they're taking care of their children, they're also working and taking care of themselves. And so when they start to feel out of
Or
control,
not taking care of themselves.
right, exactly. Like they're usually the lowest on the totem pole. And
Yeah.
that is usually what brings them in is they're realizing that the brain fog is really affecting them at work. They can't find their words. They walk into a room and they can't find or remember what they went in there for. And so all of those things are impacting them to perform optimally. And when things start to, unravel in that way, women also like often come to our office and kind of sit in front of us and they're like, I'm ready to create a plan of action. And that's what I really like treating those women is because we can create a plan that's individualized, comprehensive for them to feel their best and finally perform optimally at work, at home, and also feel good in their bodies.
Yeah, absolutely. So with perimenopause and treating that population, what was the moment you knew it was that? Like when you're diving into the research or supporting patients, like what was the moment you knew this is who I want?
I mean, I don't know if there was like a particular moment. I think during like
You mean you didn't get, like, struck by lightning and just
no, I don't remember like sitting there thinking that, but I was in my 3rd year kind of thinking, okay, picking my 4th year, we had to pick our kind of shifts in the clinic of what we were interested in. I knew I didn't want to do fertility. I didn't want to do pediatrics.
Mhm.
I didn't want to do cancer care. So I'm like, where do I kind of fit? And I'm like, I
Yeah.
know I love women's health and supporting women in that way. I mean, we just understand each other's bodies more than men do. I just want like we just know, we just do. And
Yeah.
so, what is kind of another stage of life that all women are going to have to go through? And menopause is that, right? Every single
Yeah.
woman who has a uterus will eventually stop bleeding and eventually go through menopause. And this is where women really often feel dismissed, unheard, and suffer in
Mhm.
silence, historically. And so I'm like, I
Even
think,
now.
yeah,
Yeah.
even now.
Like, I wish we could say historically, but honestly,
I
just
know.
having been at the menopause show, you're just like, "Oh, damn." Like, there really isn't care like we're providing that's easily accessible,
I
which
know.
I think sometimes we forget internally too, right?
You're right. And you know what? I've had multiple patients who sit in front of me emotional because they were like, I wish that I knew this information sooner. Because sometimes they're, outside the window of opportunity to prescribe hormone therapy. And I'm like, is
Mhm.
it too late for me? And I'm like, there's so many other ways that we can support you as well, not just through hormone therapy. But these women, wish that they had this information in perimenopause or even in their 30s to know what to expect from their bodies when they reach that age. And so, in my 4th year, I knew that I wanted to in that menopause route. I dove into the research, bought menopause textbooks, or started to dive down podcasts, listen to people who were also treating patients in that way. And then, yeah, from there, I've seen exclusively perimenopause, menopausal patients, and I love it.
I'm giggling because you guys don't have the pleasure of knowing Natalie and how borderline obsessive compulsive she is about things. Girl is early, she's on top of it, she's got the everything perfectly in play. So
Yeah.
I can only imagine the textbooks, the courses. Now you're sweating. You're like,
First
when is
one.
this
Yeah.
girl giving me away? Right? But I can only imagine the amount of focus and dedication that went into that experience, just even again, knowing the little bit that I do about your approach to care, so
I mean, I'm lucky I have a supportive partner because for years, like on weekends, I would just literally like hide in our office and turn off the lights and literally watch like 8 hours of videos and then like watch it again and retype all the notes. But I think it's important because when people sit in front of me, they want the most up to date research, they want to know what to do.
yeah.
And luckily, I do feel really confident in facilitating that conversation with patients. And so I'm grateful that I did all of that, and I continue to do it. I mean, obviously, AWH fosters an amazing continuing education for all
Mhm.
practitioners. And so even your perimenopause and menopausal course, right? Like I listened to that twice. First time listened to it, second time
Mhm.
took notes to it, but I continuously learn like little tidbits that maybe I didn't know before or that I can implement with my
Yeah,
patients tomorrow. And so I think, as a practitioner, I really like doing that, but I also feel like I owe it to patients as well.
totally.
Today's episode is brought to you by none other than Advanced Women's Health. If you are interested in diving in deeper to your health, if you are finally ready to feel like yourself, and you are finally over hearing everything's normal, everything's fine, and you want a deeper dive into your healthcare, then we are here to help you. We are currently helping patients in British Columbia and Ontario, Canada. But don't worry, if you're in another province, still reach out, get added to the wait list as we expand coast to coast. We cannot wait to work with you. Check out the show notes for more information on how to get started.
So let's go with, because you had said something that I think is so powerful, and we all have these moments. And so as soon as people say it, I just want to grab onto it. You're like, people sit in my office and they're like, I wish I knew X sooner. What are some of those conversations that you're having where people are like, I wish I knew this sooner? Because we have the platform, we have the audience right now. Like, let's really get that word out. What are the key things that you on a day to day basis are like, oh my gosh, I wish they knew?
Well, one of the things is that we know that as soon as we hit 40, or we start to kind of see that decline and degeneration in our muscles, right? And then we often see women coming in and saying that they have weight gain around their midsection that they've never experienced before. while eating the same diet and exercising in the same way. But when our body ages and our muscles start to degenerate, we know that, it sends a signal to our brain to say we need to fuel our bodies more, and we need protein to do that, to stop that signal for our muscles not to degenerate. And so we need an increased amount of protein, as we start to age. For women, we need to lift weights. I mean, I know people have heard it time and time again, but it's so important to create and maintain that muscle mass. And then another thing that I really wish that people knew is that we do not have to wait until menopause to start hormone therapy. Okay.
The study came out like yesterday or the day before, the 21st,
Yeah.
that showed that the earlier you start estradiol in perimenopause, the less cardiovascular breast cancer outcomes. It was, I can send it to you if you didn't read it already. I was just like,
Yeah.
there she is.
And
There
that's the
she
thing, right?
is.
Like, people think, oh, I've been suffering with these symptoms, but I was told that I can't get any help until I'm past menopause. And I'm like, oh my God, I could have helped you not experience these symptoms for the past 3 years. Right. And that's when a lot of people start to get emotional, because they're like, I was just waiting because of this misinformation that they've had. So that is probably like the number one things that I really wish women knew prior to entering this phase of life, is knowing that, if they're starting to have brain fog, vasomotor symptoms, meaning night sweats or hot flashes, if they're, waking up at 3 a.m. and unable to fall back asleep, okay, something is going on. And so come into the office, have a conversation with a trusted healthcare practitioner, and we can look at hormones and discuss that. But we can also look at, as you know, in that peri-chaos window, look at blood sugar levels and stress levels, sleep, all of these things that impact our health as well during this time, and kind of talk about what that looks like for each individualized patient.
Yeah. So then when you're having the conversation around HRT and perimenopause, what does that look like? I think that's one of the questions that we get a lot. And I record little snippets on it and things, but I really do think you can't hear it enough times. How are you, as a healthcare provider, helping a patient to understand when to pull the trigger on hormones? And again, I'm going to caveat this. You're an individual based on how high your cholesterol is, what your blood pressure looks like, your history of smoking, clots, cancers. We're having different conversations with everyone, but we can generalize it as much as we're often like, oh, you can't. You can. There's a category of people that are high risk. There's the mass majority of people that are not. So in that mass majority of people that are not high risk, how are you having that conversation to say, you know what, maybe now is the moment that we would look at hormones?
That's a great question. And you're right. It's individualized to each patient. Each person that sits in front of me, I definitely have a gauge of whether or not they've read a lot of research studies themselves, because a lot of women, even though some are not informed in hormone therapy, social media is starting to have a lot more information available for people. And so I do like to gauge, how deep in the rabbit hole they've gone. So then maybe I can bust myths or confirm some of the things that they're saying. So that's first and foremost what I do with patients. Secondly, if I'm having that conversation about hormone therapy, we've already done a panel of blood work and we've already discussed nutrition, right? We know that a food insulin demand diet and following that is really helpful to even have an impact on hot flashes and night sweats and weight loss. And we are, having a conversation on stress support, on, sleep hygiene and all those things. And if that's kind of understood, then we kind of dive into hormone therapy, right? And it's always the question of, is this patient, 42, and the main issue that they're having is severe anxiety and insomnia? Do we just need to give them some progesterone, right? We know that it helps or attaches to the GABA receptors in the brain and kind of allows them to take a deep breath, fall asleep, stay asleep. GABA kind of allows us to relax, allows us to go to sleep. Some people can chew on GABA as well, right? And for some patients who are patients of practitioners in AWH, you may have been given this, right? And it's a quick amino acid that helps to relax the body. And so we know that progesterone does that same thing. It attaches to those GABA receptors and it can increase, relaxation and help people fall asleep and stay asleep. And that's why people who are prescribed progesterone are given the instructions to take it at night, right? We can do it transdermally, we can do it orally.
Oh yeah, you feel like drunk.
Yes, you do. And I mean, with my experience too, and all my hormonal fluctuations, I've had transdermal progesterone. So I can attest to that. Like I have to take it at night and like it makes such a difference. I had 11 hours of sleep last night. Like that's great.
Now I know we
And
love that for you.
love that.
No children.
I had to be ready for you, Sarah. But 11,
Marty's like, get to bed.
11 hours.
Your brain has to fire.
He's like, get to bed, 11 hours of sleep and 2 cups of coffee. So, I mean, progesterone is really powerful. And so always, if it's an early perimenopausal patient, I'm just wondering if that's where I need to start. If people are getting vasomotor symptoms, we like severe night sweats, hot flashes, or even if they're not severe, right? Maybe they feel like those hot flushes, but it's still impacting their quality of life. They're having brain fog. Then I have the conversation about, okay, with the addition of following proper nutrition, advice, movement in the body, supporting our bodies with, stress support and adequate sleep, then we can incorporate estrogen, progesterone, because we know that that's the gold standard to reduce vasomotor symptoms. And so I always, have that conversation about what that looks like. I have my estrogen on my desk here and I can show them, whether we use a gel or we use a patch, how we use it transdermally. And then we have to make sure that we're taking that oral progesterone at the same time to protect that endometrial lining. Right? If patients have an IUD, if they have a hysterectomy, they don't necessarily need that progesterone piece, but we can incorporate it if there is, sleep issues or anxiety. And so, and in addition to that's a conversation that I have, but I also always do a cardiovascular risk calculation with them, using their lipid panel that I did, blood pressure and any medications that they're on, and make sure and confirm that they're a low candidate and a good candidate for hormone therapy. And then I also do a breast cancer risk calculation with every patient because there's still a fear from the Women's Health Initiative that was done in the early 2000s that this will cause breast cancer. And so I definitely have a lengthy conversation about what does their breast cancer risk look like now? What does it look like when we give hormone therapy? And what does it look like from other lifestyle points of view, like drinking wine, being overweight, not exercising, smoking. And so people feel really comfortable, I would say, leaving my office with that prescription, knowing what these hormones are going to do for them.
Yeah. And I want to clarify what Dr. Natalie is saying there is that if you drink alcohol, if you are overweight, if you're not moving your body, if you're smoking, your chances of getting breast cancer statistically in the average person is significantly higher than it would be by taking hormone replacement therapy. And we now again have some studies that show that we possibly could see a decline in breast cancer rates in people who start these hormones early. Very individual, but I think I am always extremely mindful about how I word things in these conversations because people want to look at this like we're saying there's a dramatic increase. It is still something that I will say something and someone will go home and they spin the words and they're like, well, you said I was at risk of breast. And you're like, oh, wow. Okay, we're still here. But again, I think we need to understand that. What I always say to people is we walk through the world with glasses on. Okay. And those glasses have different lenses, and those lenses change our perception. The world looks different. The sky looks different. The water looks different if you're wearing polarized glasses or not. If you're wearing purple tinted, brown tinted, black tinted glasses or no glasses, it just changes what your perception is. And your perception is reality, right? I always go back to my children. My kiddos have sunglasses. They have different colors. And so the boys will be like, why is the sky green? And I'm like, it's not. Take off your glasses. I'm like, no, it is. And I'm like, I understand. It feels like it is right now. Take off your glasses. And they'll take them off and they'll be like, oh, it's blue. Why is it blue? Well, then we can have a conversation about perception and lens. But the reality is many people are coming into this conversation with red colored glasses. They think it is risky. They think it is dangerous. They think that this is hugely detrimental. And so I'm like, can you just come into this conversation with your glasses off? And be open to what research we have available in this moment. Sometimes the answer is yes, sometimes the answer is no, which is totally fine. Either way, HRT is not for everyone, but I think it's really important that everyone is coming into every conversation knowing what their bias is and having that at the forefront. Because I'll have patients in the room and I'm sitting there talking to them. And again, you're going through these calculators and you can see they're stressed. And I'm like, okay, I understand right now. I see what's happening in your body. Even if you don't know what's happening in your mind, you feel this is a stressful conversation. It is not a different conversation than should you take vitamin D or iron. It's not. It's just looking at everything we put in our body has a risk. It's just when you go to the LCBO, they don't make you do a breast cancer risk assessment.
Exactly. And what makes patients feel even more comfortable, not only are you spending, an hour sometimes like talking to them about risks and benefits and the expectations and the possible side effects of the estrogen and progesterone piece, I'm also sending them home with, okay, how does this increase blood clot risk? Does this increase, colon cancer risk? Does this increase my breast cancer risk? Does it decrease osteoporosis risk? And so there's a nice page that you created, right, that we can send patients home with that gives us all information. And so this is all research based, and they can kind of go home with it, see it, take some time to think about it, right? Because I always tell them, I'm like, I'm ready to prescribe this to you if you want relief. If you want to take some time and kind of look this over, you're totally welcome to do that too.
Absolutely. I was talking to a patient. She's been my patient since she was in her 20s, and she is going through menopause early. And so I said to her, like, listen, dude, we need to do this. Like, we need to do this because when you're going through early, there are many more risk factors. And so she's in her late 30s right now. And we were having that conversation. And I said, take your time. The reality is, most of the time when I'm having conversations with patients, step one is we introduce the conversation and we go through, again, Natalie was referencing. So I took all of the research that's available and put it on like a 2-pager just so that people can see the statistics in what we call absolute risk, not relative risk. So what does that mean? Absolute risk means you go from 8 to 9 people out of 10,000 had cancer. That's 1 out of 10,000. Relative risk is like, oh, well, it increased X percentage, right? So it feels a lot more scary. But in those situations, I expect that you're going to go home and review that. I expect you're going to come back with questions. Then I expect that you're going to get the answer to those questions and go home and review that. Then you will probably come back. You may or may not have tried a hormone. For some reason, my patients love to try one and not the other. And so then you're going to come back and we're going to check in and see how that goes and then try the other one. There is still a lot of fear around this. It is okay. It takes, on average, I would say 3 visits to get really comfortable with hormones and probably like 6 months to find the optimal dosage. It's not something that we expect to happen one time. And I think that's something that's really helpful for people to hear because I have a lot of patients apologizing coming back. And I'm like, no, this is the norm. It is the norm to have questions. It is good that you are making an informed decision about your body. And it's just in the medical world right now, if one complaint 7 minutes, I think there is that feeling of like, I just have to take whatever I'm given and accept that's my option. And if I can book back in and talk about a different concern, but if I book back in to ask yet another question about the same thing, it feels like you're taking away from someone else. I'm like, in my office, you're not taking anything from anyone. This is your time and it's so important. For some patients, we come in, talk, everything makes sense, HRT visit 1, slap it on their ass, and they walk out the door. It's totally fine. But if you're not that person and you have a lot of questions, it is okay. Like, we are very used to that. We can answer those questions for you, can help you march down that path, and we can customize that hormonal experience as you go. And I've been meaning to record something on this because I think, again, we're still in this world that so many women apologize for getting the answers they want, asking those things. Like, we're in a world where there's still people apologizing about their body. And if it takes you a year to decide to do hormones, I don't care. It's not like a personal attack on me. You know what I mean? Like, I'm going to continue to march on knowing I answered your questions, and that's all that matters. And so I really want people to hear that there's no one way to go about this. You can get as much or as little information as you want. And that is, again, such an important thing for people to know.
Exactly. And can we just go back really quickly when you said how important it is to have hormone therapy if somebody's going through menopause earlier, especially than the average age of menopause, like you referenced your patient like in her 20s. And I think it's important too, and I wish more women knew that, if they go through a hysterectomy and even keep their ovaries, they are still at a twofold increase of going through menopause earlier than the average age. We know that 20% of people that go through and have a hysterectomy because of heavy bleeding or what have you, we know that they will have menopausal symptoms within the first year after the hysterectomy. And so I get a lot of patients that are in my office and they've had a hysterectomy, but they were never told, okay, you probably will get menopausal symptoms earlier than the average age. And there are options for you on what to do. And so I've had a lot of women, 4 or 5 years post hysterectomy, and they've gone to their doctor's office and they are explaining some of their symptoms and they are dismissed. And, it's so validating for them to sit in my office and realize that this is a reason why they're probably experiencing the symptoms. And then there are solutions for it.
One of my favorites that I talk about a lot is the fallopian tube removal, or like someone having their quote unquote tubes tied. For some people, that happens in their early 30s. For some people, it's their late 20s. They're like, I'm done having kids. And then they're experiencing these symptoms and they're told, you're in your 20s, you're in your 30s. That is absolutely not real. We're not testing you for perimenopause. You must be crazy. And I've been practicing longer than the research existed that told us that was a fact, right? That women could lose hormone and like the blood supply to the ovaries is cut off, that we would see decreased hormone production, earlier menopause, all these types of things. That wasn't fact when I was seeing these people, but you cannot deny it when you see it over and over again. And then again, because I have the luxury of doing hormone testing, doing some of these serial hormones and seeing, okay, this is not good, right? And then being able to correct that is such an important thing. But we talk about hysterectomy, but there's this whole category of women that were like, I don't want to get pregnant, cut it out, and then are suffering.
Exactly. And I see women who are 36, 37, having the classic perimenopause symptoms that if somebody didn't have their tubes tied or didn't have any kind of, abdominal surgeries, that would usually present in my office at around maybe 45, 48. And so they are a few years earlier than I would normally see patients. And some patients don't even think to write it down on their intake form that they've had their tubes tied. And so that's a question that I have to ask. And I say, has there been, any kind of tubal ligation, right? And they're like, yeah, I actually did get that a few years ago. And I'm like, okay, so this is why you're experiencing these symptoms then.
Yeah, totally. So you mentioned you have hormones on your desk.
Yeah.
I would love you to pull those out. And just for anyone who's listening on audio, if you want to see this, we do have this on YouTube and on video as well. But let's just look at what some of those options are, because I think it's such a valuable thing for people to see.
Totally. So the one that I prescribe the most is estrogen. Okay. And this is in a pump form. It's a gel and it contains FDA approved estradiol. And so this is applied to outer arms or thighs. We usually indicate to rotate areas when we prescribe. And so this is a favorite. This is applied daily for patients. I also give the option for patients if they want a patch. And so this is Estradot. It can come in different strengths. And so this is Estradot 50 that I have right here that I'm holding up. And you change the patch twice a week. Okay, usually we apply it to our hip region, but for different reasons. Some people think that applying the gel is easier because it's a daily thing. Other people want the patch. And so we just provide those options and go through pros and cons of each. The other one that I have here is Divigel, and I'll just quickly open it up here and show patients or people who are watching on video that they're in little sachets here. And this is a gel as well. And so often if people are traveling or they're, especially for work a lot, they will throw a few of these into their, luggage instead of taking the entire pump of gel. And then the other one that I do not have here is for genitourinary symptoms. And that would be Vagifem, right? And I do prescribe that a lot for vaginal irritation, bleeding, thinning of vaginal tissues, vaginal dryness. And although that's an uncomfortable conversation for some people to have, I do feel like I'm in that position where I have to ask about it for patients because we know that once we lose estrogen, it's not coming back unless we're using exogenous estrogen. And so people often experience, a lack of intimacy for years with their partner because of pain, because of dryness, and they didn't even know it was an option to put estrogen in the vaginal canal, and this can help with lubrication.
Yeah, and there's so many studies now that show that the amount of women experiencing genitourinary symptoms, vaginal dryness, discomfort, pain with intercourse, it's like less than 20% of them actually bring it up in a doctor's visit. It's such a small percentage of people. And so, one, I always say we get a lot of people who come here because they're like, women's health, they're good with vaginas. Let's have this conversation. But I think it is our job to ask, right? Like, is this something that you need support with? Are we doing this in a proactive way? Seeing your estradiol is non existent, like, this is going to happen, everyone. Your vagina will dry out at some point. Just a little PSA, it will happen. And that puts you at increased risk of UTIs, of yeast infections, of like, there's some research coming out now on prolapse. There's like all of these things that can happen. So if you have a vagina, it will be dry if you do not have hormones in it. And I think just stating it that frankly, like sometimes when I'm talking to patients, I'll say, okay, perfect. Are we talking about vaginal options, whether that's vaginal estradiol, et cetera, today? Or do you want to talk about that next time? It's like, and just putting it in that way, I think normalizes it. And again, helps people to understand, like, if you have a vagina and you are not on hormones, you will have issues. And so we need to just normalize that conversation and support people through that. And I think we will see that shift. There's some things that I honestly never thought I would see shift in my medical career, but that's one of them, because probably by the end of next year, the FDA will take all of the scary warnings off vaginal hormones, which is such a huge step for people to feel more comfortable.
And people who are using VagiFem don't have to use progesterone, like oral progesterone, right? So it is kind of nice. And if people are nervous still about hormone therapy in the vaginal canal, we can use, a non-hormonal options. I prescribe like a hyaluronic acid with vitamin E to bring water and attract water molecules to pump up the tissue, which is nice. And you can use that also at the same time. So there's a lot of flexibility with prescriptions, and a lot of options. And if people kind of need bite-sized chunks in order to, take the next step into kind of maybe using vaginal estrogen, we provide those options too.
And again, this is where I always say, it's like a menu. You know what I mean?
Yeah.
You just kind of walk in and you're like, okay, we're going to do a little of this and a little of this. And just like your favorite restaurant, you don't have to eat everything in one day. Like, just walk your way through it. Whatever feels good, whatever allows you to feel supported in that moment, go for it, because we have the luxury of having these long-term conversations with people. And that's why I say, like, are we touching the vag today or not literally? Don't worry, everyone who just freaked out. But are we going to touch on the conversation around your vaginal health today or in the future? Because, like, it's coming. So when do you want it to be? And it's, again, such a powerful thing to have that conversation.
Exactly. And I know we touched on kind of what is the conversation like prior to prescribing hormones. And I think it's important just to touch on what's the conversation like after we prescribe hormones, because it's not just a set it and forget it prescription, right? You mentioned that we often need up to 6 months to alter dose. And so I just want to let, patients who are interested in possibly getting hormone therapy in the future know that we give a prescription. We usually follow up after 3 months, right, to assess dosage, route of administration. And then from there, if everything, is good, unless we're working on other things, I need to see them at least every 6 months to follow up. And then once a year, I redo lipid panel, right? And that's our cholesterol, do a whole cardiovascular risk calculation again to make sure that they're still great candidates, and reassess, like, do we still need to be on this, and have that discussion with them.
Yeah. And that, to be clear, that doesn't mean every year, because I know we hear this all the time. It doesn't mean every year we're trying to force you off of it, because we hear people in that situation as well. I was just talking to a bunch of people on the weekend, and they were like, yeah, I go in to see my doctor and they're like, okay, perfect. Your symptoms are gone. You can come off your hormones now. And I was like, what?
Well,
so we do not know. We do not have in the research a set stopping point. And I know you were just going to say that. You like leaned in. We don't know when that's going to be. That's why we consistently need to collaborate on that conversation.
Exactly. And that's what I tell patients as well, is it used to be, okay, put them on the lowest dose for the shortest period of time. And then now we're not seeing that, right? We can stay on it for, long term. There's no end date right now.
Exactly. Exactly. Well, is there anything else that you would like people to know about yourself, your practice, that menopausal conversation? I'm sure this will be the first of many conversations. And at the time of this recording, Natalie has a webinar coming out. So it may have already passed, but you guys can always get the recording on our website as well, which goes into, again, more detail on nutrition in this area as well.
Exactly. And for that webinar, like Dr. Ali and I will be doing it together. But I really want to let listeners and viewers know that it's really important to take a proactive approach with your health, right? And so even if you are prior to the age of menopause and even in that perimenopausal window, even if you're early, it's important to step in that office space and have an informed and educated discussion about what to expect.
Yeah.
What are your symptoms now? What are everything at baseline for you? And what can I expect? And what are the symptoms I should watch out for? And when should I come and see you next, right? Because there's so many other things that we can do around this time that just don't focus on hormone therapy. And in addition, in my practice, what I focus on a lot is even in postmenopausal women, right? I focus a lot on cardiovascular health, reduction of osteoporosis, prevention of cognitive decline, which are 3 areas that we know estrogen impacts and that we know, impact women of a later age. And I really focus on optimal health and longevity. And I really like that part of my practice because women can still be, independent, intelligent, witty, all the things until the end, right? And so I really want to focus that and make sure that all women feel empowered leaving my office. So that's my main goal as a practitioner, is not only educating and informing women, even in their 30s, 40s, 50s, but even 60 plus.
Absolutely. Absolutely. And one thing we can do too is put some of those calculators in the show notes. Again, it is very common that people get overwhelmed and don't know how to use them. It's best to use them with a provider. But if you were seeing a practitioner and they are making generalized recommendations for you without actually running those numbers, then at least it gives you a way to start to have those conversations. Because I think that's one of the questions I get is, well, my doctor said I'm at high risk of XYZ, so I can't have hormones. I'm like, okay, well, based on what? Right. So if you can see the numbers and they're telling you something different than your provider is telling you, I think that's another way to get empowered and have some of these conversations. So.
Exactly. That'd be great.
Well, thank you, Natalie, for coming on. It was such a joy chatting with you. For anyone in Ontario, if you are looking for hormone replacement therapy and Dr. Natalie's approach has resonated, or you just want to learn more about it, then she can work with you virtually. And of course, to our beautiful Sudbury people, you guys need more help up there with menopause literate docs than anywhere else, I swear. So you can go in person. So thank you so much for coming on.
Thank you for having me, Sarah.
Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.